So, um, as Tim said, I'm Pete Rose. I'm leading the epilepsy service here for children at Peterborough for the past almost 1 year now. I'm hoping to make my life easier and the lives of my fellow epileptologists in the region easier by just giving you sort of some insight into what we see on the other side. Hopefully that will be of some use to you. Okay. This is an interactivity warning. So I've designed this talk to be very conversational and interactive. So it's going to depend very heavily on Menti polls. And the first question is just to give me an idea of what types of seizures you've most commonly encountered in your practice so far. That's kind of what I expected. So the generalized seizures being by far the most common that you've encountered, and then others more rarely. So that's kind of what I was expecting. So my next question to you is that if you saw a child having a seizure in your department, what immediate actions would you take? And you can select as many options as you like. Okay, so a fairly mixed response there. Okay, so this is the aspect that Timos and I were quite keen to get across to you. So like Dan said earlier, the emergency doesn't really exist until 5 minutes has elapsed. And you have to remember, one of the things that we forget is that families have to live with the uncertainty of whether or not this is going to happen to them again. I'm just going to illustrate that point to you. Now, none of these things are wrong, but what I would probably try to emphasize to you is to just hang fire for a few minutes. I'm just going to show you the difference in environment. So this is a picture of a typical emergency department resuscitation bay. There you have access to monitoring and timers, transport ventilators if you need them, drugs, oxygen. That's the environment you're in. That's the environment that families live with. So they have absolutely none of that. And basically all they can do is make sure that the surroundings are safe, and there's not much else they can do other than time it. It's quite difficult to reassure families that they can live with a future seizure safely if in the emergency department or on the ward, and the acute paediatric wards are equally guilty of this as well, of responding to an emergency that doesn't quite yet exist. And 5 minutes is a surprisingly long time, and I'm going to illustrate that with the next slide. I'm going to stop sharing my screen for a moment. And this is a natural pause point. So I just want to sort of ask how that felt, that length of time. It's quite a long time, isn't it? So, when I say most seizures subside within 2 or 3 minutes, even that is quite a long time to restrain yourself from intervening, isn't it? Now, you all as acute clinicians, your instinct is to intervene immediately. But if you think about how that makes the parents feel and how that might frighten them. Now, it's absolutely appropriate to intervene when it goes on and on, because as Dan rightly said, the longer a seizure goes on for beyond 5 minutes, the less likely it is to spontaneously terminate. And the longer it proceeds, the less likely it is to respond to medications. What we have to remember is that it really is necessary, if we can try to just restrain ourselves for that small amount of time, so that what we're doing aligns with what we're advising. Because that makes my life as an epileptologist much easier in clinic. The hardest cases I have to manage in a first fit clinic are those where their child had an episode in the hospital, either on the children's ward or in the emergency department, and the emergency buzzer's pulled and 20 people turn up and fuss around their child. You can imagine how that looks from a parent's perspective. And then I come along in clinic and say, oh no, you don't need to do any of that. It just sets up an element of doubt in the parent's mind. Well, if the emergency department and the ward are doing this and you're telling us to do the other, who's right? The fact is that both are right, but from different perspectives. So if you can, try to stay cool, even though you may be terrified yourself, because seizures aren't very nice to look at for anybody, whether or not they're clinical or otherwise. Right, I'm going to try and get my screen back up now, so bear with me a moment. On to our next question. So again, I just want to get a sense of your lived experience in PEDS ED. So if you could rank these scenarios in order of how frequently you see them, The first option is seizures witnessed by you or a colleague during their ED attendance, witnessed by the parents themselves as a first-hand account, or witnessed by a third party, such as a teacher or a friend. Marvelous, thank you. So that's pretty much what I was expecting. These children very rarely misbehave in hospital. They're very rarely going to have an event in the emergency department. And if you choose to refer them for admission, they very rarely go on to have another episode while they're being observed in hospital. So admitting them for the purpose of trying to capture one is no good, because it almost never happens. The majority are witnessed firsthand by the parents, but it's quite difficult for them to describe exactly what they've seen or to accurately give you an estimate as to the time, because when they're frightened, time tends to expand. Seconds become minutes, minutes become hours. So unless they've taken a specific note of the time at the onset and the offset, which nearly none have done on the first time, then it can be very difficult for them to estimate the duration. It's even more difficult when the account comes from a description from a third party, such as a description from a teacher or an equivalent age child friend, because the description of the event is difficult enough from a first-hand account. A second-hand account is even more prone to miscommunication, which is one of the reasons why we never, ever make a diagnosis of epilepsy based on description alone, because it's often misleading. So I just want to ask you which of the selection of investigations you would do routinely for a child presenting to your emergency department with their first unprovoked afebrile seizure. Well, you're making me as an epileptologist very, very happy, because the main two are blood glucose and ECG. I would absolutely want to know the results of both of those tests in a referral to my First Fit service. Now, there's a couple of reasons why. So the first is, particularly in younger age groups, acute hypoglycemia is a relatively common provocation for a seizure. So technically, that would not be an unprovoked first seizure, as it would be directly caused by the acute hypoglycemia. If you correct the hypoglycemia, that usually is enough by itself to terminate the seizure. We touched on ECGs in Dan's talk as well. So the main reason we want to record an ECG is to look for any sign of arrhythmia or arrhythmiogenicity. So we're particularly interested in the corrected QT interval, mainly from a perspective of thinking ahead. So quite a number of the anti-seizure medicines prolong the QT interval as a side effect by the nature of how they work. So we would absolutely want to know that the baseline, their corrected QT interval is normal as a bare minimum. Most ECGs and blood glucoses are normal in this sort of scenario, but it's important that they're done and documented for those reasons. Now, blood tests in general, there's a bit of a difference of opinion here between NICE and the British Paediatric Neurology Association. So NICE will say to bleed everyone. The BPNA, on the other hand, are a little bit more judicious. Now, as you're all quite well aware, taking a blood sample from a child is not a trivial procedure. It is quite labor intensive and traumatic for the child. So we only really want to do them if we're going to get a good yield. And these tests are nearly always totally normal in this sort of scenario. Now, on the contrary, if they've come in status epilepticus, it comes through resus, you've got IV access for the administration of intravenous anti-seizure medications, it's perfectly appropriate to opportunistically take the blood test there. I'm not going to ask you to contravene any local guidelines that you have. If they say take the bloods, do as you're told, but they're of lesser importance, because the principle is that a seizure provoked by any biochemical anomaly will persist until that biochemical anomaly is corrected. So in this sort of scenario, next to none of those are going to be abnormal, and including the blood glucose. As for acute imaging, there's nearly no role for acute CT scan, except for some very, 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 very rare presentations, which I'm not going to go into today. So my next question to you is, which cases do you routinely refer acutely to the paediatricians? Okay, lovely. A nice split amongst you. So I agree with some of you. So certainly, if there is any suspicion of focality to the seizures, So if they were unilateral features that progressed into generalized features, so that would be a focal onset generalized seizure, or if it's purely focal features, then at minimum, it would be best to discuss those cases with the acute pediatric team, just because they have a slightly higher likelihood of having some intracranial pathology that might require a little bit more urgency in neuroimaging. That's not always true, but it's worthy of the discussion. Certainly prolonged seizures, particularly those that you've had to intervene that with buccal, rectal, or intravenous anti-seizure medications, they would definitely need to be admitted to let them sleep off them benzodiazepines and to have an initial workup done on an inpatient basis. So clusters, similarly to status epilepticus, you may have intervened with those ones, and they, in a similar manner to the prolonged seizures, they would potentially need to be admitted. Now, some of you said all cases. Would be perfectly happy to discuss any case that you want to talk to us about. But the vast majority of young people with first unprovoked afebrile seizures do not require admission to hospital unless there are other circumstances. For example, if there are lots of scenarios where you might want to for the purpose of reassurance. So if it's late at night, if you've not been able to calm the parents down, answer their concerns. But in the main, most people are successfully discharged without onward referral, but we're quite happy to come and speak to them if you're not successful at reassuring them sufficiently to go home from the emergency department. Interestingly, fairly low percentage of you have said to talk about the under twos. I would encourage you to discuss any child with their first seizure that presents under the age of 2 years, because this group is quite a bit more likely to have more complex epilepsy syndrome, if that's ultimately what it is. And I, as a secondary care paediatrician with an interest in epilepsy, will refer all under 2 years olds to the paediatric neurologist so that they're involved in their care, even if I'm going to be managing them mostly and they don't need to get too closely involved, because as a group, they are more likely to have some of the nastier epilepsy syndromes. Okay. So this next question is going to be a two-part question. So I'm looking to see what advice you routinely give to parents when you discharge them from your emergency department. Okay, so people have said the EPEN first seizure leaflet, dependence on the situation, the RCPCH leaflet. Yeah, good. First aid swimming, bathroom knocks, bath time swimming advice. Capture further events on video. I like all that. So I like all of those responses, so I agree with all of them. I'm glad that you're all familiar with the RCPCH and the EPEN leaflets, so those are my go-tos. The RCPCH leaflet is particularly good as it has a lot of the features that are often more subtle and people don't think to look out for in a table in the event that a subsequent episode happens, so that the parents can give us a more detailed description in the clinic should one happen before we see them. I hope you appreciated if one of these events were to happen at home, that 5 minutes is an eternity, isn't it? So it gives them something to do if you ask them to look carefully for those features and, if possible, to video the event. A lot of parents are resistant to the idea of taking a video with a mobile phone of their child during a seizure because it does go against their instincts. So there are a few things to mention with that. So we don't need the whole event because that would not be realistic. We never, ever capture the onset of the event. So when it comes to the description, we do ask parents to give us a little bit of information about what happened at the beginning. And when you see the child, it's worth asking them if they have any recollections at the onset of the event too. And the video, we only need about 15 seconds worth to make a determination of whether the event looks epileptic or non-epileptic, or we're not sure, because that's about as much as it gives us. What we do like to do, though, is to give some tips. So it's important that where possible, the child is uncovered. You'll be surprised at the number of videos I get with the head in a dark room with the arms and legs obscured by bed sheets. Another thing we ask people not to do is to orbit their child with the camera, because then it makes it a little bit harder to lateralize symptoms, so orientating yourself relative to the child on the video. So we ask people to just stay in a fixed position, uncover their child, and take a 10 to 15 second video with the child's whole body, if possible, in the frame with a slight zoom into their face, so we can see of any facial features that might be happening. And that's all we need. We don't need them, the offset of the seizure to be captured in the video necessarily, unless it's a relatively brief one. But it also is useful in terms of timing the event as well, because the timer on the video recording helps them with timing. So we emphasize safety. So all the parents can realistically do is make sure that the surrounding of the child are safe. They're not going to fall off anything or pull anything onto themselves during their seizures that potentially injured themselves. Beyond that, there's not much else they can do apart from video it. And as people have rightly said, if by 5 minutes it's showing no signs of stopping, then they must, of course, call 999. If they have a history of seizures, they will usually have been advised at that point to give their rescue medication if they've been prescribed it. And the benefit of giving the PCH leaflet is that lots of parents forget most of the things that we tell them in an acute consultation. They tend to remember the beginning and end, but they miss out a lot of the middle portion of their consultation. So giving them something to refer to in writing is quite useful. And for those who aren't familiar with the RCPCH leaflet, at the end of my presentation, I've got a QR code that takes you to the website to download it. And they now have 2 leaflets. They have one for the parents and one for the children themselves. It's well worth familiarizing yourself with both of those, because the advice in there is the same advice that you should be giving them when you see them in the ED. Okay. Right. So here's a question for you. What proportion of patients will go on to have a second seizure within 2 years of their first? Well, I'm very impressed. So the majority of you got that right. So 4 out of 10 children who've had their first unprovoked afebrile paroxysmal episode will go on to have another within the next 2 years, which means that 6 out of 10 won't. So the whole purpose of the First Fit clinic is to try to differentiate those 2 groups. Interestingly, what happens is if they go on to have a second seizure, that flips around. So if they have a second, they're 6 out of 10 of those will go on to have further episodes. So that's the group that we want to capture, because they're more likely to end up with a diagnosis of epilepsy than the others. So well done. I'm impressed. So next, I want to see if you know the diagnostic criteria for making a diagnosis of epilepsy. So which of these do you think need to be fulfilled to make a diagnosis? Okay, wonderful. Okay, and once again, I'm impressed. The majority is correct. So any one of these criteria would need to be fulfilled to make a diagnosis of epilepsy. So these are the diagnostic criteria set forth by the International League Against Epilepsy, which is the international group that provides the guidance surrounding the epilepsies and their management. So the most common way we diagnose epilepsy is that first group. So the 2 unprovoked paroxysmal episodes that appear epileptic that occur at least 24 hours apart. That first day, they might have multiple episodes in that day, but they don't count. So that'll be considered one episode of events rather than distinct events. And then they have to go on to have other events, or at least 24 hours after their most recent one, for them to fulfill that criteria. And even then, it's possible to misdiagnose these as epilepsy without exceedingly careful history and video. The second criteria is actually the rarest. So 1 unprovoked paroxysmal episode that appears epileptic, but with a greater than 60% risk of recurrence. So that group in pediatric population would probably be those who, I'm trying to think off the top of my head, what would that count under? So if you had a child who, as a neonate, for example, had hypoxic ischemic events perinatally, for which they were treated on the NICU, as a group, they have a higher recurrence risk after a first paroxysmal episode. So that's probably the rarest one. And then the presence of features consistent with one of the named epilepsy syndromes is difficult to fulfill without investigations, because the majority of them have EEG and MRI criteria to make a diagnosis. But there are a couple where you might be able to diagnose those clinically. But from a first episode, it's highly unlikely that you would fulfill that third criterion. So next, I'm going to ask you what you think that I do as the epileptologist in the first seizure clinic. I'll give you a clue. So my new patient clinics are 45 minutes long. So if that helps you, go ahead and put as many answers as you like. Now, and while I'm waiting, Timos, is there any activity in the chat?
I have one here.
Oh, neurofibromatosis. So if you have clinical signs of neurofibromatosis, they would probably meet the second criterion after their first episode, potentially. But again, that's not 100%. So we would probably need to investigate those further to determine whether the event was epileptic or not. We would probably not diagnose them on the basis of a first event, but we would have a higher index of suspicion.
I have another question.
Yep, go ahead.
The question is, so anything in ED which come under a future consistent with epilepsy syndrome?
Okay, so the only one I can think of that you might capture is a very classical presentation of infantile epileptic spasms. But even then, we can't make the diagnosis without further investigation. So it's really difficult to fulfill that criterion on the basis of a first episode. That's something that you would usually evolve over time or with the results of investigations. So from an ED perspective, the most likely scenario where we would begin to entertain the diagnosis of epilepsy would be multiple paroxysmal events that appear epileptic in nature. Okay, so I'm just going to stop sharing my screen and close the voting on this because I've got quite a few responses. Okay, so these are the responses I've got. So lots of people have said history, neuroexam, history. I'm very pleased to see that because, yes, the majority of information comes from a very detailed clinical history. Syndromic diagnosis. Eventually, yes. So that's the aim. The aim of a new patient epilepsy clinic is to first decide whether from the history or from any video that we have, whether or not the events are likely to be epileptic, non-epileptic, or whether or not we can't tell. So the key there is history, videos of events if we can get them, and time. Epilepsy is not a single diagnosis. It's an umbrella term that covers multiple diagnoses. There are about 50 or 60 individual epilepsy syndromes, which we eventually try to categorize patients into if we're able to. And each of them have different criteria. So features of the seizures themselves, EEG findings, both ictally and interictally, imaging findings. And a lot of the time, the situation evolves over time. So it's a process of over follow-up, constantly refining our diagnosis, because sometimes we can't get all the way down to one of the syndromes. We can only get part of the way down the tree. So if we decide that it's epileptic, the next phase is then to decide whether or not the onset of the seizures are generalized, focal, indeterminate, and then if they're focal, do they generalize? Can we localize them from the history and investigations to a particular area? And if they're generalized, how often they're occurring, how long are they? In terms of neurological examination, it's nearly always normal, but it's certainly important to do in every case in childhood. You can't get away without examining them. And it's particularly important for those with any focality to their symptoms. Now, imaging is more important with those who are having focal symptoms because as a group, they are more likely to have a lesional cause for their epilepsy, but even then it's still quite rare. So nearly all the MRIs I request are reported to be normal. And as a group, the least likely cause is a tumor. The most common lesional epilepsies are focal areas of cortical maldevelopment, so focal cortical dysplasia, or areas that were damaged from a perinatal hypoxic ischemic event, so in localized encephalomalacia. So those are the more common lesional causes. If there's been a history of focal seizures on a background of frequent or atypical febrile convulsions, then one of the things that we look out for there is mesial temporal sclerosis. So that's visible on MRI scans. So the importance of MRI is greater for those with focal seizures. Those who have generalized seizures will still scan them, but less urgently, and nearly always their scans are normal. But that's useful information nonetheless. Which leads me to EEG. So nearly all of our patients will have an EEG requested. It's not the magic bullet people think it is. So EEG has around about 50% sensitivity and specificity. So it's not powerful enough to rule in or rule out epilepsy. So the majority of people who have had their first seizure will have a completely normal EEG. So we tend to wait for them to have at least 2 events before we request one, unless video evidence is quite compelling. Now, most interictal EEGs, so that means EEGs between seizures, are normal, because if you're not having symptoms, the traces on an EEG often look normal. If you have a child who has neurodivergence, so autism spectrum disorders or ADHD, they as a group are a little bit more likely to develop an epilepsy syndrome during their lifetime. But they often have indeterminate abnormal brain waves on their EEG as part of their neurodivergence. So it's important to mention that in the request, so the EEG can be interpreted in light of that. You have to be extraordinarily lucky on a standard EEG to detect a seizure. And for those unfamiliar with EEG, the way a standard EEG is done is that they wire the patient up and they sit them there for 15 minutes just to see what the brain does. And then for the final 5 minutes of a 20-minute recording, they do provocation testing. So there are 2 steps to that. So if the child is old enough and cooperative enough, we'll try to hyperventilate them. So we'll get them blowing a little windmill for at least 3 minutes to see if that attenuates their EEG recording to give us a little bit more useful information, or indeed induces a seizure. And for absence epilepsy, that nearly always gets us a diagnosis. And failing that, the next provocation that we can do in a routine EEG is photic stimulation. So where we bombard the child with increasingly frequent light pulses until either they have changes, and everyone has changes in response to photic stimulation, but there are ways of telling pathological from physiological apart, and the EEG teams are good at differentiating that for us on the report. If you have a normal EEG and you go on to have episodes, then the final type of EEG you can do in most settings is a sleep deprived or a sleep EEG. So you either deprive them of sleep, let them have a late night the night before, and then do their recording late in the afternoon the following day. Or you can chemically induce sleep with melatonin to see if sleep triggers them. So between the changes in phases of sleep, so going from awake to asleep and from the sleep to awake is often a trigger for seizure activity for a number of the epilepsy syndromes. And it's often quite a good way of stressing the brain enough to get useful information from the EEG. But if you've gone ahead and done a normal EEG, which is normal, and a sleep EEG, which is normal, and we're still having events, then they would often need onward referral to the tertiary centre where they can perform ambulatory EEG, so a prolonged recording with video telemetry. But there's only a handful of patients that end up needing that. So they tend to be the ones where the videos are equivocal or unobtainable. The events are relatively frequent, and the history doesn't strongly suggest either way, whether it's epileptic or non-epileptic. But there are a few occasions where we would have to do that to see if we can capture an event to definitively say one way or the other. But EEG is easy to abuse because you can't simply ask query epilepsy and get any meaningful information. So it's best to request an EEG in a similar way that you'd request a scan. So give them a clue as to what you're looking for. So if you're suspecting activity on a particular side, so if there's focal symptoms, you can describe that so they can look at the relevant areas a little bit more closely. If the child is neurodivergent or not, that's important to mention. Their developmental progress is also important. If you have an inkling of what the epilepsy syndrome might be, then it's useful to put that in, because if that's one that's associated with particular EEG findings or particular provocations during EEG recording, then that can get you more useful information. So let's have a look at the others. Yes, so checking over the investigation done in the emergency department, very important. And it saves a great deal of time if you've done the blood glucose and the ECG. Often we don't need the full 12-lead ECG, so some of the more uncooperative children, if you just get the limb leads, that'll be enough for most cases. All we're really looking for there is to assess the QT interval, and we can do that from the rhythm strip if that's all we get. So some EEG is better than no EEG. The ECG, sorry. It's easy to confuse those, isn't it? And the main thrust of the First Fit clinic is to reiterate the safety advice and to reassure the family. We tend not to go down the road of talking about sudden unexpected death in epilepsy on the First Fit clinic, unless the parents bring that up specifically, because that's quite a loaded conversation. But if a parent does ask about that, then we're quite upfront about it. So we say that yes, as a group, those children that do end up with a diagnosis of epilepsy are at greater risk than the general population of sudden death, but the risk is, as a group, is quite small, although there are certain epilepsy syndromes where the risk is much, much greater, and there are features in the history that make the risk greater as well. But that's something best left until we've formalized the diagnosis and can have that more detailed conversation. Let's see, is there anything else I've missed from there? I think that was all of it. So lovely. So if there is a very strong family history, goes down sort of the matrilineal or the patrilineal line, that is certainly a worthy reason to do genetic testing. If they're young onset, so if they're under the age of 3, I would offer it, because they as a group will more likely have a higher pickup rate for the genetic causes of epilepsy. Anyone who's had a lesional epilepsy as well, there are panels to do for that. So yeah, so there is an increasing sort of single gene testing. We do whole genome sequencing, and the epilepsy services are one of the early adopters of whole genome sequencing. And the utility of the whole genome sequencing is that they periodically rerun the analysis after it's initially tested. So what we do is we don't just test the child, we test both parents as well if they consent to do so. But as you can imagine, because we're taking detailed genetic and genomic data from 3 individuals, the consent process for that is quite lengthy. So I have to arrange a separate telephone appointment to go through the consent process. So what I would do if I'm offering it to families in the First Fit service is to give them the written information about that and let them consider it. And if they want to proceed, they can contact us and we can arrange to formalize the consent process and make the necessary arrangements. So I've got a couple more slides to show you before I just open the floor to questions. Most of you are already familiar with the RCPCH leaflet, but those of you aren't and are interested in looking at it, if you scan that QR code with your smartphone, that will take you directly to the main page for those leaflets on the RCPCH website. But if you go on to Google and type RCPCH first seizure leaflet, that'll be the top hit. So that's another way of getting it. And then finally, for those who are interested in learning more, so the International League Against Epilepsy has a website, epilepsydiagnosis.org, which is the diagnostic manual for the epilepsies. So that gives you everything you could possibly want to know about the various epilepsies, and you can make a free account with that website, which will give you access to a library of videos for various seizure types at various ages. So this is good for adult epilepsy as well as childhood epilepsy. It's quite an easy to use website. It has all of the epilepsy syndromes, all of the epilepsy mimics. So I highly recommend that you explore that in your own time. And for those who are interested in learning a bit more detail of the children's epilepsies, BPNA run their Paediatric epilepsy training courses. So that's a 3-stage course. PET 1, which is the first stage, is a 1-day course that is intended for every clinician who might encounter children presenting with one of the epilepsies. So that's general pediatricians, pediatric emergency doctors, pediatric epilepsy nurses, pediatric ward nurses, general practitioners, anyone who wants to learn more detail about epilepsy in childhood. You don't have to go through the entire 3-stage course. The second and the third PET courses are for those like me who are developing their specialist interest. Okay. So that's it from me, unless anyone has any questions, and I'd like to thank you all for your kind attention.
When do you believe that we have prescribed emergency drugs to the children?
Okay, so we generally wouldn't prescribe rescue medications after their first episode, even if it was prolonged, mainly because at that point we haven't yet diagnosed them with an epilepsy, and we would certainly want them to present acutely if that were to happen recurrently. That said, if it does happen recurrently and they're consistently prolonged, then yes, we would train and provide rescue medications. There are lots of considerations for that. The majority actually don't end up having rescue medications at home. It's only those who have a reliably recurrent history of prolonged episodes.
Thank you.
Or if they have one of the more dangerous epilepsy syndromes, like Dravet syndrome, for example.
Hi, thank you for the presentation. I have a quick question is,
Interictal EEGs are often normal, and sleep-deprived EEGs can still be normal, and you can still have epilepsy. So in that case, the utility of the EEG in that situation is that in between episodes, their brain is behaving normally. And that actually rules out a good number of the epilepsy syndromes, because some of those require abnormalities in between events as well as during events. So it's still not useless, but it doesn't bring you close to the diagnosis of epilepsy. But if they've had recurrent episodes and you have video that is convincing that they look epileptic, then you can diagnose them on that basis and begin treatment. Not every epilepsy requires treatment, and initiating treatment is a big commitment. So if you initiate treatment, you're committing them to a minimum of 2 years of daily medication. And part of the reason that we're cautious about initiating treatment is that we don't want to expose those who ultimately do not have epilepsy to an anti-seizure medicine, because it won't be a benefit to them, and it'll all be risk rather than benefit. But the other element is that we want to be very clear that we have a decent enough understanding of the nature of the episodes to make an appropriate selection, because there are some forms of epilepsy for which certain anti-seizure medicines can make the situation worse. And the classic example of that is exposing someone with absence epilepsy to carbamazepine. It will make them worse. So we definitely want to be careful. The other element about deciding whether or not treatment's appropriate is how often the seizures are happening. So if you're having a 2-minute generalized seizure twice a year, most people would not choose to treat them, because taking daily medicines for something that happens 6 monthly, the risk-benefit scenario there is a little bit dubious. And also gauging whether or not the medication is actually working is quite difficult. On the contrary, if they're having multiple episodes per week, that's an entirely different situation, and you would certainly want to medicate those. Does that answer your question?
yeah, that's nice. Yeah, so basically it's what I gathered in a normal development child with no syndromic diagnosis. It's primarily how much is affecting their life and parental expectations and the duration and severity of the seizure.
Absolutely.
Thank you.
Now, what the parents say to you about the experience they have in ED?
Okay. So the majority of children don't have episodes during their attendance to the ED. So the majority, they've had an episode either at home or at school or somewhere in between, and they've presented to the emergency department following that. They don't go on to have another. And in those cases, that's quite simple, because you give them the RCPCH leaflet in most cases. Most have given perfectly appropriate and sensible advice. That group is quite easy. The difficulty is if they've had an event in the hospital and all hell has broken loose and everyone has descended upon them, that really, really frightens the parents. And when you explain to them that there's time to take a step back, wait, see how long it goes on for, take some video, it takes a great deal of convincing them that that's actually safe to do. And like I said before, it's not just primarily an emergency department issue, it's an acute ward issue as well. Myself and the children's epilepsy specialist nurses are constantly banging their heads against the wall when it comes to trying to convince our nursing colleagues, and in my case, my medical colleagues, that you have time. It's important not to respond to an emergency that doesn't yet exist, because we need to keep in mind that these families are going to have to live with this, and they don't have access to oxygen, they don't have access to monitoring. All they've got is a bedroom with nothing in it. So it's just keeping that perspective. That group can be quite a challenge to bring their fear levels down. Usually it takes a little time, but they get there eventually once they have a little bit more experience and they see, actually, yes, it looks horrible. It tends to burn itself out. In most seizures last under a minute, but that minute is an eternity if you've never witnessed this sort of thing before. So you have to acknowledge the fear, but if you give them careful parameters to follow as to when they should begin to worry, which is what the point of the RCPCH leaflet is, then their fear levels do come down. And the other thing is by referring them to your epilepsy service, that gives them access to the children's epilepsy specialist nurses, who are an absolutely amazing resource, because they can give very practical and useful advice to families in between clinic appointments. So it's well worth getting to know your children's epilepsy nurses locally, because they can give you a lot of guidance if you're unsure on what to advise.
I have one more question.
Of course.
For another doctor.
So infantile epileptic spasms, they often are subtle. So they can be difficult to diagnose, because they look often like completely benign movements of the baby. So they can look like hiccups, they can look like startling episodes, they can just look like normal baby movements. And if you have doubt about it, they don't necessarily need an overnight admission, but they certainly need discussion. I can only speak for my local environment, because I've got a wonderful EEG department that will move heaven and earth for the babies. So it's entirely possible that I can make a planned admission for them for the purposes of having an EEG. And it's important for them to have sleep as part of the EEG to detect the hypsarrhythmia, because it tends to manifest itself in transition from awake state to sleep state and back and forth. And in infants, that's quite easy to do. You just give them a good feed and wrap them up, and then they settle. And in epileptic spasms, the events are often enough that you should be able to capture one on a standard recording quite easily. And it's basically the only indication for a urgent EEG. The rest can happen in their own time. But epileptic spasms is important. Now, the hope was that intervening early, when you've identified epileptic spasms, will improve their development. Sadly, that doesn't seem to have been borne out. So the development will do what it wants to do. But the benefit of identifying and treating them early is actually in terms of their seizure burden later in their life. If you attack it aggressively at an early stage, you might not preserve the development as much as we would have hoped, but you certainly do diminish their seizure burden later.
So my question is, you said that's a very interesting way of looking at things, that when children come to A&E, we by default do the blood glucose and the blood gas. And I have seen so many variations. Some old school consultants, they don't like to do any interventions for first seizure. What's your expert opinion, so I can take it as a take-home message?
Okay, so yeah, in every case, I would certainly do the glucose, and if you can, in every case, I would certainly do the ECG as a bare minimum. Now, local guidelines vary. National guidelines are in conflict. So if you did the PET1 course, they de-emphasize blood testing in children with seizures, except in a fairly narrow set of circumstances. So greater utility in the small babies, but you should be referring them in anyway. So that'll be done for you by the paediatric team. And there are a number of particularly specialist investigations that we wouldn't expect the emergency department to do. But in the majority of cases, there's very little to no utility. Now, NICE will tell you to bleed everybody, but that's because it's a guideline that sort of combines children and adults together and smushes them as one Greek homogeneous lump. The BPNA, who run the PET courses, say that there's not a great deal of yield outside of the infant onset epilepsies, which should be sent to the paediatricians acutely anyway. So from an ED perspective, I would say I would not quibble with you if you make a referral to me with only an ECG and a blood glucose. I would be very satisfied with that.
You say.
Yeah, so very few need hyperacute neuroimaging. The only exception to that would be if you're thinking something quite rare. So childhood stroke would be one. That's quite a rare one. If you've got localized neurological signs that make you suspect that there might be a space occupying lesion, then that's another one that we would do it reasonably quickly on. The majority of our neuroimaging is done on either a routine or an urgent outpatient basis, but it depends on your local availability. So again, here in Peterborough, our radiology department's pretty good, and we have a regular list for MRIs under general anaesthetic, which makes our life a little bit easier, and we're quite lucky compared to other centres for that. There's very little reason to request imaging from the emergency department perspective. That would be something for me to do. So it's not something we would expect you to organise at all. But if you can give us the history that gives us the clues that it might be necessary, that's where you can be most helpful.
Thank you.
Time.
It was amazing. Thank you very much, Dr. Rose.
You're very welcome.
Both of you. It was amazing to have you today. And thank you very much also the PEMeast, I can see him, for the organization. I really appreciate that.